welcome you all to this imaging session. We have a very eminent list of speakers here, and they will be focusing on various aspects of multimodality imaging. The first speaker is Dr. Rakesh Gupta. So he needs no introduction, a very familiar face, well-known cardiologist and very passionate about echo, and he has contributed immensely in the field of echo in every ways. And he will be talking about the role of GLS. Dr. Rakesh.
Thank you very much, Dr. Mahapatra, and my own friend, colleague sitting over here, Dr. Satish Govind, and everybody out in the offset. This is one modality which I believe over a period of time has really made a lot of difference in clinical practice. When we talk of a GLS, and majority of lab, they do not do it at all. And this is one modality which can really prevent the onset of heart failure when we can identify them at a much earlier stage. That's what I'm going to talk about in next 12 minutes. Most important thing is I have to put in my thoughts, my practice, my experience into the guidelines based how do we do it. If you look at our heart failure, it's a structure abnormality, whether it comes from a valves or valves. It's a function which can be assessed by 2D Doppler or GLS and the filling pressure. These important three things makes a classical diagnosis of heart failure. And you look at the study of a universal definition and classical classification of heart failure published in 2021. They look at a clinical syndrome with current or prior symptoms, signs caused by structural function cardiac illnesses. Collaborated by anti-BNP, pro-BNP or anti-pro-BNP levels, along with the objective evidence of cardiac pulmonary systemic congestion. Then the next important thing is a person who is at a pre-heart failure stage. That's where our role really comes into play. Like we can pick up these people at this particular level. Then our role comes when we talk of a heart failure with preserved ejection fraction. Somebody has got a reduced ejection fraction. Everybody knows the patient has already gone into heart failure. So I'll spend some time on these few ideas which I have in my mind. Here's a 54-year-old male, type 2 diabetic, routine echo evaluation, no prior history of any illness, cardiac, respiratory, whatever it is. And here, look at his LV function. All my colleagues sitting over here, they can spend a time. Every one of us say, look, he has got absolutely normal LV systolic function. If not absolutely, at least ejection fraction would be more than 50% of ejection fraction, whether it's 3-chamber, Flax view, 4-chamber or a 2-chamber, reasonably good LV contraction. We went on to do what next we should do. I say we should go on to do a global longitudinal stain. I picked up an individual frame in this particular patient. Look, 3-chamber view, you can look at a very classical difference. These mid and basal anterior septum, they are poorly contracting. And on top of that, they show a positive deformation despite the systolic contraction has been going on. Similarly, we look at the 4-chamber view, which every one of us devotes time. It tells you a normal LV systolic function. Look what exactly happened. Post-systolic thickening is still happening, despite some section has shown almost a contraction complete, while the subsegment are showing a post-systolic contraction. And once we look at a 2-chamber view, still the same thing which is present over. It's not only that the LV function is down, but at the same time, it is telling you, look, these are the segments which are showing dyssynchrony, not only a synchronization contraction. And we look at a polar map of this particular person. It's minus 11.8, despite all these normal functions which we show. What is this patient is a cardiomyopathy or stage B heart failure? That's what their importance is. Mind my word, he's a person who's a diabetic, no symptomatology, and he's right now in a cardiomyopathy. And that's where we need to have a hit. And that's what has been said in this paper published in 2021. Diabetic cardiomyopathy with proposed role of metformin, that's the different part. But if you look at these kind of a factor which cause a myocardial dysfunction, impaired GLS is one of the most important modalities which can make a diagnosis. That's true if you let's start using GLS. And this is one another part. If you use metformin, it helps you not changing a GLS to a large extent, but certainly helps in assessing the filling pressures. The other part of a heart failure is like metformin helps in assessing, telling you, look, your filling pressures have become better over a period of time in diabetes mellitus. Mean to say that you can really look at a GLS for assessment of pre-heart failure or stage B heart failure evaluation for LV systolic function, as well as it tells you about therapeutics of the evaluation when you use a metformin. Look, these people, if they had a higher filling pressures, they became normal. Let's go to another study which talks of a diagnosis of non-ischemic stage B heart failure with type 2 diabetes, optimal parameter for prediction of heart failure. Look, if these people, they have a GLS of less than 16 versus more than 16, look at the incidence of cumulative incidence of developing heart failure over a period of time. So what do? We should have these kind of evaluation right at the beginning, not at the time when people have already developed a heart failure. It's not only that, this one particular study talks something more. Multiple risk factor, multiple assessing factor, what we need an assessment. Poor HbA1c, every one of us is doing. We don't look at an LVH, we don't look at an LA enlargement, we don't look at LV filling patterns. And on top of that, if you add impaired GLS, look, this graph tells you the chances of survival, 0 stage B heart failure feature versus more than 1. Here the graph separates dramatically in the subset of versus if these factors, they keep on rising from 0 to 3, look at the chances of survival function. Means to say that more the higher the risk factor, more chances of these people developing a stage B heart failure. Hence, GLS is one most important modality, talks of a subclinical LV dysfunction, which is prevalent in asymptomatic elderly patients in type 2 diabetes, and this is independent and more incremental to LVH prediction of incident of heart failure. Mind you, this is one most important thing which we hardly do in our diabetic subjects. So it helps not only in diagnosis, but in therapeutics values. I showed you one of the slides. Time does not permit to show you more. Then early diagnostic of diastolic heart failure. I have put on this slide deliberately. L is stands for categorization of LV diastolic dysfunction. Many times people, they come with subclinical, not a subclinical, normal LV systolic function, but dyspnea on exertion. And I've seen many people in our practice being labeled as mild coronary artery disease. This is where their diastolic function is normal in resting period. If we do a passive leg raising test or we do a LS strain, we can really unearth the presence of isolated diastolic dysfunction, where these people are in dynamic diastolic dysfunction or stress-induced diastolic heart failure. And this can be easily evaluated by LS strain analysis in these subset of population. Very commonly available as on today. It's not a modality which is not available. Every second machine has this kind of availability. Let's talk of prognostic significance. We always say ejection fraction is useful. Look at this graph of ejection fraction over here versus this graph of a GLS over here. As the GLS increases, the probability of survival dramatically decreases over a period of time. So much of so is said, each 1% increase in GLS is associated with more than 5% decreased risk of mortality. And that's what tells you about the prognostic value of GLS in acute heart failure. Many of us, they always do LVB evaluations and we say LV function is normal. What do we do next? We don't know what we do next. Let's look at these two important slides of this particular paper. They talk of ejection fraction more than 50% versus GLS less than 12%. Here is a graph which talks of almost this particular phenomenon. As the ejection fraction decreases and GLS becomes more and more, and look at this graph which is going all the way down. So it helps in letting you know how much is the predictive value of particular GLS is. And not only that, GLS is the most robust factor when we assess the prediction of subsequent heart failure in these people of LVB. And here is this particular phenomena, which talks of a GLS alone gives you much better value than any ejection fraction or other twist and other mechanism of evaluation of heart failure. Another important point, we talked of ischemic cardiomyopathy. Here is a person of ischemic cardiomyopathy, live from our lab, talking of this kind of phenomena. Look, poor LV systolic function. Dr. Rupali was very categorically telling you about, look, if their anti-proBNP becomes normal, they have a better profile. Yes, I do agree with that. If I say that these things, you transport them into a GLS format, you look at the GLS at the time of a discharge, and put on this graph, if the GLS is less than 7 versus more than 7, look how much is a percentage of people they will survive over a period of time. It's not a rocket science. It can be done each and everybody in their lab, and majority of them, they can be adopted in a clinical practice. And what need to have a good imaging quality, and then put on a papers, look, his GLS is more than 7 versus less than 7. This has been further amplified by this particular study, talking of 3 tertiles: lower, middle, and higher. As the GLS increases, I mean to say is, if my GLS is 17 or more, when is the cutoff value is, the cumulative survival is much higher if my GLS is much less on this. And this adequately tells you the importance of GLS in clinical practice for predictions. One more thing which talks about in heart failure: ejection fraction less than 22, more than 22. If you look at this less than 22 ejection fraction, you need a GLS more than 5.9 versus less than 5.9. You add RV systolic function to this. If the GLS is less than 0.59 and the TAPSE or RV systolic function is less than 1.2, or the TAPSE is poor, look at the cumulative over a period of time. So outcome of abnormal functional reserve with heart failure and preserved ejection fraction, if you put them on exercise, you're able to know what is their future outcome would be. Then role of a GLS in heart failure, I showed you this is what the prognostic value is. The take-home message is good early diagnosis, whether systolic or diastolic, absolute good prognostic value. And many of the paper will tell you, with like you do a ARNI, you do a beta blocker, you give them a diuretics and reverse remodeling, which is happening after the development of ARNI. This helps you really predicting how much your GLS is improved over a period of time. And that's what it talks about. Thank you very much. I'll say with this slide, GLS or no GLS in heart failure, it's all yours. And thank you very much for your patience here.
Thank you, Dr. Rakesh. As always, an excellent presentation touching on almost every aspect of how GLS has come to rule the heart failure assessment. You touched upon every point.